on the Super Bowl. It's cold, it's raining, but we're going to try to make this this webinar as enjoyable as possible. Today we're going to be talking about the substance use disorder system of care that we have here in Los Angeles County. Myself, my name is Maurilio Mendez. Everyone calls me Leo. I work for a division called Substance Abuse Prevention and Control in an area called the Strategic Planning and Network Division. And I've been working for the substance use area for over a decade now. I worked a little bit, about 10 years at the state level and various areas. Specifically today, we're going to talk about our system of care. I also wanted to introduce to you all actually two of my colleagues that are here. I'm going to have her introduce herself. Her name is Miss Natalie Mendez. So, Natalie?
Good morning, everyone. I'm Natalie Mendez. I'm the Family Services Manager here at Substance Abuse Prevention and Control in our systems of care. And we currently take care of any family service program, whether it's DCFS, perinatal, CalWorks, and that type of thing. So we're going to go into detail about the perinatal network once Leo gets through with his first piece.
Excellent.
So good morning.
Awesome. Thank you, Natalie. Also we have here today is Miss Julie Mongi. She's one of our newest analysts here in substance abuse prevention and control. And Julie, would you like to say a few words about yourself?
Good morning, everyone. I just joined with the Marketing and Beneficiary Engagement Unit with SASH, Substance Abuse Prevention and Control. This morning, I'm just offering support to Leo and Natalie and to you all.
Excellent. Thank you, Julie. So today, you'll hear a lot of acronyms. As a government agency, we love using acronyms. So if there's anything that we go through today, if you have any questions on any acronyms that we are using or anything at all, please feel free to use the chat section, chat feature. We'll be addressing any of the questions after the webinar has been completed. I know a lot of individuals, the term substance use disorder is fairly new. We are talking about addiction of alcohol and drugs. And so we're going to talk a little bit about where the system was before, how we've changed within the last year and a half, and what we aim to go towards in the future. So all that being said, let's go to the agenda for today. So through this webinar today, we're going to talk specifically about substance use disorders. What's the difference between a substance use disorder versus addiction versus all the other terms that we've commonly heard when we hear about addiction. Also, we're going to talk a little bit more about some background and trends that we see here in Los Angeles County in terms of people entering in for treatment in the system of care, what types of substances that are commonly used or people that are being treated for within the system of care. Also, we're going to talk about the new system of care. It's called START ODS. I believe we just refer to it by ODS now, the Organized Delivery System of Care. A little bit, we're going to talk about strategies to enhance client care, kind of like what ways can we get individuals interested in substance use treatment, and then we'll open it up to next steps and any questions that you all may have. So as Substance Abuse Prevention and Control, the Division of Substance Abuse Prevention and Control of the LA County Public Health, we are committed to reducing the impact of substance abuse and addiction throughout LA County. When we say that, we do take lead. We have over 78 agencies, I believe, and over 300 sites across LA County. And also, we lead and facilitate a spectrum of prevention and treatment services throughout the county. And when I say a spectrum, depending on the severity of an individual coming into our system, we can and provide them with the specific type of service that's meeting their specific level of care that they need. Thank you, Natalie. Natalie showed me a shortcut on how to use the slides. I'm learning things today. Cool. So usually these are questions that we throw out to the group, and you can use the chat area. I think it would be interesting for us to know a little bit more about who you are and what you do. In terms of, you can use the chat function right now. And we kind of want to know, in your system, in terms of what you do, who provides a referral to individuals in addiction, and how does that referral look like? Also, where do you refer people who need assistance, who have substance use disorders, and what are some successes or opportunities that you see in terms of this area?
Maurilio, I just wanted to check in with you. We don't, we're not seeing any slides changing. It's still on your cover slide. Is that accurate?
Oh no, you should see slides changing. So let me see. Let's see. Oh, for some reason it was paused. So here we go. Now do you see referral process for substance abuse?
We see a folder.
A folder.
On the application, it says it's paused. Open it back up.
Oh, you know what?
Hold on.
You have a dual.
Do that.
Here we go.
It says it's paused.
Oh, let's see here. This is pausing the screen.
There we go.
Cool. So now you're
All right.
doing referral
See the
process?
referral process.
Okay, cool.
Yep. Okay. All right. Thank you.
Okay, cool. Okay, so I'll mess with this as little as I can. And so from what my understanding is that a lot of you work with individuals who are pregnant or who have young children, that some of them may need assistance for addiction treatment services. And I think just to kind of give you a little bit of a background, how you all kind of come to know about our services and what we do, I think the original question that came to us was in regards to marijuana use and the effects of marijuana use on a fetus, or not a fetus, a baby, when the mother is nursing and then she's smoking marijuana, and what are the effects on the child during nursing. And so I know that was one question that was brought up at the beginning, and I think we'll handle that more towards Natalie's area because she's a lot more versed in that than I am. But overall, let's see here. Some of the things that we have heard before when we brought this question up is kind of the common things that I've heard over the years. A lot of times we've heard that it's very difficult to get individuals into the publicly funded treatment area. A lot of times, I know people have had issues. Basically, the way that it was set up, you would go and cold call any one of our providers, and pretty much you would hope that they had vacancy for you or for that individual. And if they didn't have vacancy for you, you'd get on a wait list. And a lot of times too, in our old system of care, we were severely underfunded. I know one of the areas that provided a lot of funding for the treatment was very limited because it was due to the fact that it was a block grant. So there's some things that have changed that we'll touch upon today to kind of let you guys understand why that was in terms of you kind of know a little bit about why in terms of the funding and how it was limited in terms of access, but where we're going in the future. We're using the slideshow. Here we go. So in terms of trends, what we're seeing with individuals coming into our system of care, this is kind of older data, but it still gives us a good idea of what is occurring. In terms of race, ethnicity, it actually, we're doing a fairly good job of meeting the individuals in terms of the race, ethnicity component. The individuals representing LA County are coming in at a consistent rate of what they're represented here within LA County. There's really no outliers there. In terms of admissions and unique patients, we do see a lot more of individuals coming into treatment more than one time. That's why you see the number of unique patients much lower than the admissions. And that's fairly common in addiction treatment. A lot of times an individual will need 1, 2, 3, or even more times in their course of treatment until they get they achieve recovery in substance use. Another area is in terms of age of first use. We do see, again, those younger teenage years are definitely those areas where, as individuals are introduced to substances at an earlier age, their likelihood of overall substance use addiction through their lifetime increases. So again, we are still seeing that as an area that is especially among the 12 and 17 through 17-year-olds, is a high area of need to focus our prevention efforts. And also the languages spoken that we see, again, mimic what is seen throughout LA County, English being the predominant language and the other languages spoken, mostly Spanish. We do have some individuals in certain areas. I think we're seeing areas of increase for Farsi and also Farsi, and there is another language, but it's escaping me right now. It's one of the Asian languages, but I forget what it is. So another thing that is an interesting thing that we've seen is that, again, as the opiate crisis has hit all of the United States, it does not leave LA County out. We have seen over 40.3% of individuals coming into our system of care reporting as heroin as their primary drug, followed by methamphetamine, marijuana, alcohol, prescription drugs, and least areas cocaine. We have, in our recent look at the data, there is a kind of flopping effect with heroin and methamphetamine, with methamphetamine starting to increase again. But definitely heroin and methamphetamine, I would definitely say those are the two drugs that we continuously see as individuals coming more and more into our system of care. Most people who were in our old system, again, this is looking at older data, so I have to really look at this more as what our old system had provided. Most individuals were treated through outpatient programs, meaning they were receiving counseling up to 1 hour a week, I believe. And then the next biggest area was those who were on methadone treatment. Methadone treatment is it's an opioid replacement treatment program where individuals are given methadone in terms to assist and to replace the opiate that they have been taking. Another thing that we had seen a lot were residential treatment services, and it's interesting that we did have them at 16.6%. The reason why that was probably so low was probably because more of the fact that only pregnant women were able to access the residential treatment services through our drug Medi-Cal program, and everyone else pretty much relied on SAFT block grant funded. And again, those were limited to the funds that were available. A lot of individuals would be in our old program on wait lists to get into that residential treatment program. And looking overall in LA County, we do see most of the individuals that are coming into our system of care through SPA 2, which would be the San Fernando area, followed by SPA 8, the South Bay, Long Beach area, and with the third area being the SPA 7 Southeast area. So now that you know a little bit about the common things that are happening in terms of the substances that we commonly see individuals coming in for care, what exactly is a substance use disorder? So a lot of times individuals have heard this previously as addiction, as a substance abuse disorder, there's a lot of different terms that individuals use to describe this, but basically we have all now used the term substance use disorder due to a change in the DSM-5. This change in the DSM-5 really goes and takes a look at addiction more as a disorder and ties it along in terms of finding the levels of severity that individuals are using the substances. It also includes the levels of misuse, dependence, and addiction to alcohol and both alcohol, both legal and illegal drugs. And through that area of severity, we actually take that area of severity to determine the best level of treatment to deliver to that individual. So addiction, what it is a chronic disease that affects the brain, and like many other chronic diseases like diabetes, asthma, heart disease, it can be successfully managed through lifetime intervention. Combined with the medical, mental, and social needs, by looking at all the other healthcare needs of the individual, you can actually help the individual reach a area of lifetime recovery. And it's interesting when you talk about substance use disorder as a chronic condition, it goes and it kind of makes you think about it a little bit differently. In our old system, I know we used to have areas and programs where they would kick individuals out of the program if they would relapse. And so if you think about it in terms of a chronic condition, would you kick an individual out of their doctor's office if they had diabetes and they did not follow their diet routine that was prescribed by the doctor? No, you'd kind of go and take a look at them and try to find a way to help them and reach. They would basically need a higher level of care. And basically, in looking at our system, we found the need to do that, to find ways to meet individuals who are still coming to us, needing help, and meeting them where they are at. So this right here, this is a mini video. This video, it has audio, but I don't think, it's not necessarily the audio that's important. It's more of it's a little animation, and it was provided by our medical director. And what it does is it goes and illustrates what basically addiction is with a very brief illustration. The video is called Nuggets. Again, it's more of what the video is showing. So I'm going to show the video, and then we'll talk about it a little bit. Thank you. So that was the video that's presented. I really liked the video. Again, it was provided by our medical director, Dr. Sai, and it really does give you a good illustration in terms of how an individual their brain gets hijacked. Their hijacks their reward system, and really they become dependent on the substance that's used. And this goes along with what we do see in terms of data. There's it's by the NFDUH. It's a survey that's released by SAMHSA every year. And what they found is that 96% of individuals who are surveyed that would specifically be found to be needing treatment would deny that they would even need treatment. Out of those individuals surveyed, only 3% felt that they needed any type of help, but they wouldn't make an effort to actually go to treatment. And so really we're only seeing about 1% of those individuals who feel that they need it and also who are making an effort. So I think in terms of our challenge here as a system of care, and also our challenge as healthcare providers, is that we're working with individuals who may be at all different levels of severity of use and abuse and misuse. And at times they don't even feel that they even need treatment. They feel that they're able to go and that everything's fine. So in LA County alone, it's estimated about 2 million people use substances in an unhealthy or hazardous manner. So with that challenge being said, and also I think another component that's added to this that also makes it difficult is the stigma that's still attached to individuals who have an addiction. A lot of them don't want to seek treatment because a lot of times individuals who are having issues with addiction are seen as individuals as some sort of moral failing, or they're choosing to use. So rather than thinking about it more as a disease and being able to come in for treatment to get help with the disorder that they're currently experiencing. So again, it poses a challenge to us as a system of care. So now that we got past through the old system of care, where we were at, there's actually some good news on the horizon. Actually, we are in the midst of it right now. We're in a system called the System Transformation to Advanced Recovery and Treatment. Here we call it the Organized Delivery System. And what we do with the Organized Delivery System, the County of Los Angeles had an opportunity to enter what was called a waiver system. We applied and we were accepted into the waiver system. And what this allows us to do, it allows us to do two different things. One thing is we were able to increase access for care. We were able to go and provide more services, increasing access to care that falls in line with the Affordable Care Act in terms of, instead of just providing women who were pregnant under the old drug Medi-Cal system, we were actually able to expand all of our services of care to anybody who would need it. And also we were able to go and look at our system as a medical model. With that being said, what that means is we were able to go and look at what the services we are providing and expand our services, adding areas like detox services, adding areas of adding different types of medications that we're able to help individuals with, and also increasing our capacity by bringing on more providers into our system of care. Another thing too is we become more partners with our mental health side and also our primary care side to provide what's called an organized system of care. So I'm actually going to go into a little bit about the services that we provide now. The services, when we talk about outpatient, again, we're talking about this service was provided previously, and this is what most everyone would get who qualified for drug Medi-Cal in our old system. Again, they were services of counseling for youth and adults. It was usually up to about 1 to 9 hours per week, and in those counseling sessions, they'd be provided with education, individual counseling, family therapy, crisis intervention, and most individuals would receive this level of care. The next area I'm sorry, before I move from this, another area we were able to add because of the waiver is an area called limited outpatient for at-risk. And what that is, that also provides the one-on-one counseling and group counseling, but for youth who are starting to show risk behaviors. So before they're even actually diagnosed with having a substance use disorder, we're actually able to do the intervention a lot earlier, and they're able to go in and really target that age group of 12 to 17. And with outpatient for at-risk youth, it actually goes from ages 12 to 20. Intensive outpatient treatment, again, is counseling, but a very much more intense type of counseling therapy. This is done at 19 hours per week and up to 30 hours per week. This again includes all the counseling components, case management into other areas of need. I believe the old system was 3 hours, 3 days a week, but we've actually taken out that requirement, and it allows a lot more flexibility to deliver that care throughout the week with those individuals. The next level of care that's provided is the residential treatment services. And so a lot of individuals ask us, what's the difference between a residential treatment service and an inpatient type of care setting? Well, the main difference is the residential treatment service is more therapeutical. You stay at a place that basically a lot of times looks like a house. You're there with individuals who are also dealing with the same issue, and you learn skill sets that are you're there with individuals 24/7. You learn skill sets and you apply them while you're there. A lot of times these are 30, 60, or 90-day stays, and this provides an opportunity for continuous assistance at that higher level of care. This area, again, medication-assisted treatment has always been a component of substance use, but we are now able to provide other medications to help the individual while they're in treatment. Again, medication-assisted treatment and opioid treatment, what it is there to do with methadone, buprenorphine, it really is to provide a replacement therapy to help the individual out. And so you also see disulfiram. Disulfiram is commonly used for individuals who have issues with alcohol, and naloxone therapy. Naloxone, or is it naltrexone? I think it's naloxone is actually the one, it's the opiate reversal drug that we provide for not only our providers, but we also provide for the individuals to assist in case they're in a situation where they are with an individual or they're using themselves, but it prevents overdose. And it's a very important tool to have while you're helping an individual get better. And then also with withdrawal management, you have detox services. Withdrawal management, I mean, we have a very small here, but basically those would be more kind of like your inpatient service areas. It's more of a clinical setting. In some of the areas, they're monitored with physicians and nurses to really help those individuals while they're getting off the substance that they've been using in a safe manner. So these services, they're called recovery support services, and these are services we've never had before. Recovery support services, what they aim to do is, so in our previous program, a lot of times people they'd complete treatment, they'd receive a certificate, and that would be the end of it. Well, in recovery support services, it allows for lifelong recovery. They're able to go in and continue to receive supportive counseling, supportive case management, coaching from individuals. A lot of times they're called recovery peers counselors, I believe, and those are individuals who have previously been in the substance use system to help them guide through the system, and if they have any issues while they're have completed treatment, they're able to go and report back over there. And if they have areas of relapse, they're able to get into our system much quicker with that lifelong connection. With Measure H, it introduced another area that we were able to add, which is called Recovery Bridge Housing. Now, Recovery Bridge Housing is limited to individuals who are homeless and who would be enrolled in our outpatient area. So that way we're able to go and provide them with a safe environment while treating them through their substance use disorder. Again, this is only limited to those individuals who are chronically homeless, and it does provide that area through those Measure H fundings. So as you see, in terms of all of our levels of care, we use what's called a American Society ASAM, American Society of Addiction Medication, different levels. So it really, all that you really need to remember from that is at ASAM level 1, they're receiving the lowest level of care. We have ASAM levels 1, 2, 3, and 4. At the 4th, they're receiving the highest level of care, which would be detox services in our system. And then at 2, 3, and 4, they're receiving one of those middle areas. 2 is intensive outpatient, 3 is residential. And again, through all of these areas, we also coordinate with county health agencies, our service providers, being the criminal justice system and social systems of service and community support services. All right, so I do want to say is that all of our providers, they're also incentivized to provide case management, as that is a paid benefit that we give to our providers, and they are paid to link them to the individual to other systems of care as well. So really, there is really no wrong door approach in getting into our system of care. I'm going to actually hand the presentation over to Natalie. Afterwards, we'll talk a little bit more about how to get somebody into the system of care. But right now, Natalie's going to talk a little bit specifically about the perinatal section and what perinatal benefits that we have available.
Hello, good morning again. My name is Natalie Mendez, and I'm going to be speaking about our Pregnant and Parenting Women Network. Changed the name to PPW recently because it's including not just perinatal, but we also have our parenting women. Currently, our network includes 22 PPW providers, our network with 91 sites, and including, we have a 38 active recovery bridge housing sites. So we're growing, and it's quite large. What is the network? Well, it's one of those systems that's created and governed by the California Department of Health Services to ensure our providers deliver quality substance disorder treatment. The purpose of the regulations is to make sure the funding that is set aside for this is called the Substance Abuse Prevention and Treatment Block Grant. And this set aside money is specifically for perinatal clients, regardless of whether perinatal funds are exchanged. These women and parents have intense needs, and the state has decided to set aside this funding to cover specific needs for these parents. So providers must adhere to the practice guidelines in accordance with Drug Medi-Cal and the Substance Abuse Prevention Block Grant set aside. They have to have a contract with DPH SAPC as well as a perinatal designation assigned by the state. They're also governed to adhere by Title 22 of the California Code of Regulations as well as Title 45. And they're also requiring that the families be treated as a unit, meaning the mother and the child when appropriate. So there's quite a few guidelines that our providers must adhere to with this program, and the state is constantly reaching us monthly, or actually every 6 weeks, to make sure these provisions are being adhered to. So the SUD providers serve pregnant women, of course, women with dependent children, also those that might be involved with DCFS and attempting to regain custody of their children. Again, any postpartum and anyone, let's say DCFS determined a child was exposed to substances and the child has been detained at the hospital. So the services go for quite some time, and eligibility is pregnant and postpartum up to 60 days. And a lot of this has to be determined by, of course, the parent's physician, and it must be determined, regularly as if we extend services. So it's a great benefit with us now with being START ODS, the services that can continue as long as the parent meets medical necessity, meaning their substance use issues, as well as their physical state based on what their doctor reports. The state does require that we must provide preference to pregnant injecting drug users, pregnant substance users, and injection drug users, just period. The main course is because they want to make sure the children, the baby, the fetus does not become a fatality, does not become addicted. So that's the main focus, and we want to make sure that they're constantly checking on that. So that is asked of us a lot. Our providers are also required to reach out to communities where folks aren't necessarily, willing to admit that they're having substance use. So that's part of their the requirements to not only handle that population, but also reach out and make sure the neighborhood is aware that they provide those types of services. As Leo reported, the services and provider benefits are the same, and they're all listed here. For perinatal, many of them are extended, like he indicated with OTP, residential. Everything is increased based on the mere fact that they're pregnant or parenting, and based on the benefit, services can be extended. Again, everything has to be documented, recovery bridge housing, recovery support services. All of these services are available to our pregnant and parenting women. Extended services include those 30 hours of intensive outpatient that we spoke about. Initial authorization for residential is 90 days with another 90 days and 30 days thereafter, up to 60 days based on medical necessity. And the same thing with recovery bridge housing, which is very, very necessary these days, with homeless being a big factor in many of our population's issues, and some reasons for relapse, because if they don't have a house or a place to go after they get out of residential, or they may feel forced to go back to a situation that led them to the initial situation for them being in treatment. The main focus when a parent enters any treatment, but especially pregnant or parenting patient enters treatment, is their housing situation, and the main step for all of our providers to look at that housing situation and not wait till after they're done with residential to begin looking at housing, because housing, as we all know, takes quite some time to to get set up and to find permanent housing for our individuals and our families, especially if someone's walking with 1 or 2 or 3 children or pregnant and don't want to go back to a bad situation. Although our providers are well-versed in domestic violence counseling and helping families who may have those issues and fearful of going back or having to go back to those situations. So with Recovery Bridge Housing and Recovery Support Services, our providers are really keyed in to the needs initially when a parent starts entering treatment with them to help make sure those services are met prior to release. Other partnerships and screening and intervention and education services are required by the state for all of our PPW providers. This is to minimize the risk of fetal exposure, to motivate and encourage individuals to seek or remain in treatment. Because as you know, all of us know, with treatment is never always, I want to do this right away. Sometimes, you know, just like the video demonstrated, we go back and forth, folks go back and forth, and the revolving doors. We have a lot of families, parents who are all on board one day, next day they're not on board, and a lot of that happens. So we have to have the intervention and education even while they're in treatment, and involve other partnerships. Maybe it could be a mental health provider, it could be collateral services through interventions through a church or something that their family is comfortable with. But all these partnerships, all these other services our PPW providers are aware of, and they reach out to the neighborhoods and get them involved with the families to make sure relapse is hit head on, so there's no, you know, risk to the family or the children as they continue to seek sobriety. Treatment planning, services for medical and pediatric care, therapeutic interventions for the children, case management and transportation. All of these services are provided by our PPW providers. Interim services, we don't have any wait lists. The state shies upon wait lists, and we at SAPC do not allow wait lists if there's a situation, and it happens all the time. If a family, let's say, is in Lancaster and their court, let's say their court involved with having their child detained is in Lancaster. The parent wants to be in residential in Lancaster, and let's say that agency doesn't have an opening at that time, but may have something at their Long Beach location. They have that choice, because everything with substance use, as you know, is a choice, and one must, you know, want to do it. So you want to make it available to them. If they don't want to go to those locations that are outside of their comfort zone because they have to visit with their family or go to court or meet their social worker, interim services have to be available, meaning intensive outpatient, education, intervention, groups, anything to keep that individual engaged. We just don't send them away and say, well, wait till, you know, till the bed's open and then show up. We don't do that. They have to provide interim services, and while the interim services are happening, and it looks like the bid is being delayed and the parent can't get into that slot in that location, they work with them to see, you know, maybe we can work out transportation if it's at another location to help you get back and forth to see your child, just to make sure the service is provided and they don't delay getting into care. So, I mean, they're really robust when it comes to situations like this and getting that parent the services they need while they may have to wait a day or two. As of July 1st, we added some new services where with Recovery Bridge Housing and Residential, we are including the minor children 0 to 16 who accompany their parent in residential. It also includes overnight stays for families who might be, child might be visiting. They have visitation rights through foster care. They visit a couple of days or so. So they're also able to be with them to help learn how to cope with that child, to learn to integrate that family right back. Because I know in the past it's been the parent gets residential, gets the treatment, but really doesn't know how to do the parenting skills, really is not used to getting 3 children back at once, and then relapse happens all over again. So this is to help in those situations. Our perinatal network also provide services for those children, daycare, pediatric services, intervention, transportation if the child's in school or going to medical appointments to help ease the burden off the parent while they're getting treatment. So we're really happy that we were able to provide child case management for those children. Let's say there's some developmental issues or the child is having issues, struggling with why the mom is going through these changes. Is it something I did, or their behavior issues because they're mad, because they have to be, the parent had to be detained, the child care, the daycare, all those things are really key tools in helping these families. And I guess that's pretty much it. It's a great big program, and we have a lot of our providers on the call here on this webinar today that I saw pop up. So that's it for now.
Cool. Thank you, Natalie. Yeah, it's a very exciting time, very exciting things that are happening, especially with the perinatal program. The fact that we do not separate the child and the mother in treatment. We make that a priority to have them both together, and we also reimburse our providers for providing that service, and also tying them into other supportive services for those children that are also going through. It's not only the mother that's affected by the disorder, but the child, and so making sure that all the mother and the child are linked up for those services, and also providing other benefits such as transportation and easing the burden off the mother to make sure that they can, again, I think that's one thing that I hear over and over again, ease of access. That's one thing that we've, as a system of care, we're committed to doing, and we are really, that's a major focus, especially coming into the new year, of finding ways as these individuals are willing to get treatment, we want to make it as easy as possible to access the system of care. So speaking about access specifically, I think if you don't get anything else out of this webinar today, we really want you all to pay close attention to this area. Today we're going to talk about, in this section, how to get somebody into our system of care. So our system of care actually has three main entryways to get in. Before we talk about that, we first have to talk about eligibility. You must be a LA County resident, and you also must be Medi-Cal eligible or enrolled, or My Health LA eligible or enrolled. So in terms of that, if you have an individual that needs help, and let's say they are on one of the border. We get this question a lot. They're a border city. They have their benefits at another location, but would like to seek services in our county. Our providers actually would work with them to help transfer those benefits to LA County, as long as they are LA County resident. Another thing too that we see is for those individuals who are homeless, they're able to use the DPSS site where they get their benefit as their address location, and so that would work as well as in terms of determining residency. Also, if it's unknown their Medi-Cal status or My Health LA status, we do not want to prevent that from them seeking care. So again, the provider, we work with the provider in providing up to 60 days treatment for the provider until the time of determination of Medi-Cal or My Health LA. And really, our focus is anyone that is a LA County resident, and if it's unknown their status, get them into care, and we will do that determination process. Again, there are three main entryways into the system of care. You could always go directly to one of our 300 providers directly. That's one of our most common ways that still individuals come into our system of care, through either a community center or one of our other, I believe, public health clinics. They oftentimes have established relationships with our providers, and they'll go and refer that individual directly to the provider. Another area that's used is called the Client Engagement and Navigation Service areas, and what those are areas that are co-located in areas such as probation offices, court systems, and other areas that we often would see individuals coming in needing substance use treatment. So that way we're meeting the individual at the time in their life that they're probably going to be a little bit more motivated to enter into the treatment system. And the one thing that I think is most important today that we're promoting and to let you know about as somebody that works out in the community is one of our main areas. It's called the Substance Abuse Service Helpline. We know it as the SASH line. And how that works is, I'll explain it a little bit more here in a second, but it's a 1-800 number, and it's not like any 800 number out there. You actually talk with a live person. It's not a machine. And that individual will work with the person calling to get them directly into treatment. In a second, I'll show you how that works. So the Substance Abuse Service Helpline, the number is 1-844-804-7500. And these operators are available 24 hours a day, 7 days a week, 365 days a year. You're talking to a real live person that has been trained to help an individual find their severity level and get them to the appropriate level of treatment that they'll need. In that call, they'll be screened, and it's a very short screening process that takes place. I believe the longest between 5 to 15 minutes. Through that process, they determine the best level of care, and they're able to link them with a provider and get the provider on the phone and then offer the initial intake appointment. Also, we do provide oral interpretation on that service line with all of the languages that are, I believe it's through the Medicaid program. What are those specific languages called?
Threshold languages?
Yes, thank you, Julie. With all the 13 threshold languages, so there is oral interpretation available on that line as well. Oh yeah, and another thing too, so you can be the individual that needs treatment. I would highly recommend if you have the individual with you, have them call, because it will be able to help the operator find them to the best location to get that intake appointment. But you could also call yourself if you're looking for resources for an individual. And you can let them know what specific area. They'll also ask you questions, but they won't necessarily run the assessment with you if you're not the individual. But if you have the individual with you, I highly recommend having them be there, having them be on the call, have them run through the assessment, and it will assist them in getting to the right level of care much faster. So how do our operators find vacancies in treatment? So we actually had to come up with a way of that to occur. Before, what you would do is, and what used to happen a lot of times, is we would have a printed directory out. And it was the old school way of, going through the directory, calling, and hopefully they would have an opening. And if they didn't, you'd be on the phone and going to the next one. Those days are gone. We actually require all of our treatment providers to update a vacancy list daily. On that vacancy list, our operators are able to go through, and they're able, through the assessment that they conduct, find the treatment location and special areas such as whether that person's an adult, youth, finding their gender, whether it's a male or female oriented facility or even a transgender facility that and also if an area has medication assisted treatment, if that person's physically disabled, a whole bunch of other specialty areas to ensure that person is receiving the best treatment area that has the items available that would help them out. Again, they're shown, when they run this search, they will show all of the sites that have vacancies, and then they will give them up to, they will link them with the site that will match most with that individual. And they actually they call the provider site up and link them to that provider site while that individual is on the call. If they're not able to link them up on the call, they will provide them also with 2 additional linkages to treatment that show up as well. And the whole purpose is to get them that initial intake appointment scheduled. This area was such a cool addition and so well received that SAPC actually decided to take the service bed availability tool and post it on our website. So you as a person that's just regularly in the community, if you're looking for care for somebody, you can actually go on our website and use the service and a bed availability tool to find treatment for anyone. And you have open to you the same resources that our operators are open to. Again, these are more questions to think about. And just thinking about moving ahead, have you been able to refer somebody inside addiction treatment? If so, it's good to think about the process you used. You might want to discuss the experiences, both good and bad. If you had any bad experiences recently, we want to know about it. So feel free to contact us. Our contact information is available at the end of this presentation. And in terms of SASH and SBAT, we just want to remind you to think about ways that you guys can incorporate the SASH line in your workflow, or even the SBAT in the workflow. As you're sitting there with those individuals that you're helping out, and how can you get them into treatment? And you find out you're having a conversation with a young mother, you find out they're using at an area of any type of risk, and how would you start that conversation with that individual to get them into treatment? I think those are important conversations to have. Again, I don't know all the answers to it. I wish I did, but I don't. But you never know. You know, it's one of those things that you never know when you meet an individual, and especially as somebody that's a healthcare provider, and you're sitting there talking to them about your health and just giving them the suggestion that they may want to check out substance use treatment, may be that first step in getting them to the right area. Another thing too, there are also, I know some of you on the line are nurses, there's availability to use some screening tools as well that you could incorporate in your practice that will help you identify whether or not an individual does have an issue with alcohol or drug use. And if you want to know more about those screenings, if you currently don't do that, again, feel free to contact me or Natalie, and we'll be more than happy to provide you with those resources. So another thing I guess I forgot to mention, as part of the waiver, we then act as a managed care system. And as a managed care system, we're required to give everyone their patient handbook, and that is available if you want to see. Everything that we talked about today is covered in the patient handbook, and also all this information is available on our website. And Malika, I think I had told you, but if not, if I hadn't told you, you can definitely share all of this information and share the PowerPoint with everyone on this call. Another thing that we have is the patient brochure. We have, I believe we have submitted over distributed over 15,000 brochures countywide, but this year I think we're looking to distribute over 35,000 this year. But definitely this is, there's a lot of work that's been gone into, been made in this brochure, and really getting that message out of what the services are available and how to access our care. One way I always use to remember it, I have a little jingle that I sing to myself. If you guys remember the, I don't know, I'm probably showing my age here, Sesame Street, and then there used to be that song, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. All my coworkers laugh at me. But I use that 1-844-804 or 7500, and then there you go, you'll memorize it. And another way to do it, here's a listing of all of our public health centers. These are also provide additional care throughout LA County, specifically a lot of family services, STD, tuberculosis, and immunizations as well. This is all located on our public health website. And if you have a phone on you, specifically if you have an iPhone, if you take your camera and place it against the screen right now and hold it up to that weird-looking thing that's orange on your screen, that's called a QR code. What that does is it will add all of the main contacts. It will add the SASH number, our email, and our website to your contacts in your phone. And for those of you who don't have an iPhone, if you have an Android and what's called a QR reader, it'll do the same thing, but it'll add it through that reader application. And I'll keep this area up because this is, if you go and have a question and you submit it through this area, here is our going through items such as how can you refer somebody to treatment, what types of treatments are available. Usually this is a question that we ask everyone at the end, but I think we're coming up on time, but we're open to answer any questions that you have. Here's our contact information. But again, I'll go back to the main area with the QR code. If you all have any questions, you can submit it to that area. It will still get back to us. So I'll leave this area up. And Malika, I will hand it back to you. Are there any questions for myself or Natalie?
Let's see. So I'm looking at the chat box. Does anyone have any questions? You can add them into the chat box. We have about, so as Steve is posting right now, we will be posting this webinar recording and all of the resources on the Stronger Family blog as we've been doing all of our webinars. And we will send an email with a link to the blog post when it's up. Does anyone have any questions? There was a lot of really great information. Thanks a lot to Leo and Natalie. Sahara Lutz says, thank you for the training. The helpline number will be very helpful for us if we encounter a client or family member in need of services. And then Vanessa Herrera is asking, is the SASH line specific to Medi-Cal recipients?
It is specific to Medi-Cal and MyHealthLA, but if an individual is coming and they do not know exactly if they're eligible for Medi-Cal, our recommendation is to go ahead and start there, because we even have areas, if somebody does have insurance, we'd refer them back to their insurance, but if they don't know and don't have any insurance, it still would be that would be the way to get into the system of care, to go ahead and call.
Okay, thank you. Are there any other questions? Give people another minute to type their questions in. Okay. Well, thank you. We will be sending the PowerPoint out along with the webinar recording. There was another question. Would mothers who are undocumented be able to qualify?
Yes.
The answer is yes, yes, through our My Health LA benefit. And that's one area that we've been working on. The thing that we hear back from providers is actually a lot of individuals who are undocumented in the community, especially under the current environment, are kind of afraid of even accessing care. So really the message getting back to the individuals, letting them know that treatment is a safe space, that we are there to help those individuals out, and we are really focused on the delivery of treatment.
Okay, thank you. Great webinar. There's dire help needed for perinatal vets for residential and detox with less parameters specific to this population. Comment from Darlene Walker.
Hi, Darlene. We're working on it.
Also, you know, I wanted to go back to if you're out there and you're an individual that you go and you learned all this information today, and in practice you enter an issue with helping somebody access the system, we do want to hear about it. So feel free to contact us, and we're more than happy to help figure out how to help that individual out, and also to help make our overall system of care better. Any issues that are occurring, we do want to hear about it so we can make those changes to make the system of care better.
Okay, thank you.
All right, so I think, are there any more questions, Malika?
I don't think so. So I really appreciate it. Like I said, there's really great information here, and I think that our home visitors will be able to use a lot of it and to support our families. So thank you so much. And yeah, if anyone has any other questions that come up later, would it be okay if we sent any follow-up with you later?
Definitely, yeah. That would be great.
Okay, so if anyone has any other questions for our presenters, feel free to send them over to me, and we'll try to follow up. All right.
Thank you.
So with that, we can end our presentation. Thanks again, and I hope you all have a wonderful rest of your day.
All right, thank you all. Take care. Have a great day.
Yes, you too.